Thank you for the kind introduction. It's excessive, and the ability to present here today on this. I'm going to cover some of the epidemiology and diagnosis of acute liver failure, and setting the stage for that, perhaps thinking acute liver failure is a term we all use, and for this talk I'm talking about a very specific component of that, which is acute liver failure and liver injury, where it is a primary liver insult. I'm not talking about chronic liver failure or acute on chronic liver failure. I'm not talking about the surgical causes of liver failure, nor the secondary causes, which we see perhaps more often in the ITU setting. So just talking about these two areas. Fulminant hepatic failure or acute liver failure, first defined back in 1970, with a syndrome of sudden hepatic dysfunction with no prior liver disease, so any of us, fit and healthy, and altered mentation encephalopathy within 8 weeks. How should we quantify liver failure, hepatic dysfunction? There must be absence of prior liver disease, except perhaps a couple of things. Those patients presenting with acute Wilson's, copper metabolism, and possibly HBV reactivation where there wasn't underlying chronic liver disease, and the development of encephalopathy and how we diagnose that. So most people use coagulopathy, INR or factor V level. Increasingly, I think some people are concerned that an INR of just 1.5 probably isn't distinctive enough, and it can be mixed up with septic liver coagulopathy, and we need to be very clear that this coagulopathy is liver in etiology, not septic. Well, what about encephalopathy? Well, very significant impact on mortality. If you go to more than grade 2, so for acute liver failure, that's someone who's got a GCS below 12, then you see a significant mortality versus those that have minor levels of encephalopathy, just a little bit of altered mentation. Similarly, the time to onset of encephalopathy is really important. So if you have a rapidly deteriorating encephalopathy from symptoms within the first 10 days, your chances of survival are much better than those who have a more grumbling course. And that goes slightly out of context. So the sicker the patient, the greater the chance of them getting better spontaneously. The more subacute presentations, less chance without surgical intervention in the form of liver transplant. And these are sort of pictures one sees. This is a hyperacute liver failure, that of acetaminophen or paracetamol. This is subacute liver failure, and it can get very easily confused with chronic liver disease. These patients can have ascites. When you ultrasound their liver, it can look knobbly. This area is where the liver is collapsed and effectively dying and fibrotic. These are bits of liver that are trying to regenerate, and they can look like nodules or cirrhosis when you ultrasound. So clinical history is everything. The acute and the hyperacute get encephalopathy and cerebral edema. The subacute, as I've said, jaundice and ascites. And you see this described well, hyperacute, acute and subacute liver failure, described in the Lancet 2010. Clearly coagulopathy worse in the hyperacute, very rarely deeply jaundiced, just a little jaundice, risk of intracranial hypertension, and a good spontaneous survival rate compared to the subacutes. In terms of epidemiology, this is a rare disease. It is usually young or middle-aged adults. There is a pediatric population that get liver failure. That's mainly metabolic, the neonates. And it's really seen across the world as rare, but with a high mortality. You see the incidence here, somewhere between 1.4 and 6.2 million per year. The etiology is obviously very geographically variant. So in the developing world, viral hepatitis carries the highest incidence, particularly hepatitis E and hepatitis B. Even now with vaccination, hepatitis B remains a significant challenge. In the Western world, we see much more drug-induced liver failure and less hepatitis A and hepatitis E. The hepatitis E is interesting because it's genotype dependent, and therefore the hep E that you see in the Indian subcontinent and in Africa carries a much higher mortality than the hepatitis E we see in the Western world. So if one summarizes the causes of acute liver failure, you have the viral hepatidides, A, B, B plus D, and E. In the immunocompromised population, one must think about CMV, HSV. Then there's the seronegative or indeterminate causes. They look like a virus. They might be autoimmune, not quite sure what they are. Reactivation of hepatitis B is a big issue, particularly in the Western world. We have a large immigrant population. We have a large population who have been exposed to hepatitis B but don't have liver disease. And we then give them chemotherapy, we give them rituximab, and we give them steroids, and they are at risk of going on then to reactivate their hepatitis B and get acute liver failure. And we really need to be cognizant of that and screen and use antivirals preventively. Drugs, big issue, both prescribed, recreational and herbal. Toxins, we all continue to go mushrooming in the autumn and consume Amanita phalloides. Hypoxic hepatitis, increasing incidence. It's quite interesting, that's definitely going up with an elderly population. Budd-Chiari and veno-occlusive disease, ecstasy. The pregnancy-induced liver diseases, HELP syndrome, acute fatty liver of pregnancy, and preeclampsia with liver rupture. I'll show you some pictures of that. Always be aware of lymphoma and carcinoma, characteristically high alkaline phosphatase, lower AST, and LDH often elevated. And the Wilson's disease, characterized by a low alkaline phosphatase and an evidence of Coombs negative hemolysis. So moving on to the second part of the talk, just looking at some of these diagnoses in some more detail. The viral hepatitis in the Western world definitely decreasing. This is data from the US, hepatitis A and hepatitis B. What's important in terms of investigations, you've got to be a clinician. You've got to examine these patients and take a history. You've got to feel the liver. Is it big? Is it small? Is there ascites? A full blood count and film for hemolysis. A coagulation profile and thromboelastography. A ferritin is really useful. It helps, one, in terms of the severity of the liver injury, but also as differential for hemophagocytic syndrome. Full biochemistry, immunoglobulins and autoantibodies, the viral screens with DNA for those viruses. Ultrasound of the liver, looking at Dopplers and flow, portal vein, hepatic vein, interrogating the heart. CT with contrast, not always needed. Sometimes there is a clear diagnosis without CT. Biopsy, rarely needed. And in this context, the risk for transjugular biopsy and risk of bleeding must be weighed against the diagnostic yield. So if you don't know the diagnosis, it might be cancer, it might be lymphoma, sure, go ahead and do a biopsy. If you think it's viral hepatitis, or drug-induced, there isn't an indication if they fulfill transplant criteria. The immunoglobulins do help you. In terms of this, you can see that the viral patients have much higher IgM than the drug-induced, so you can see some differential in terms of immunoglobulin profile. I'll just talk a little bit about pregnancy-related liver failure. Usually occurs in the third trimester of pregnancy. They present with capsular pain and nausea. The risk sometimes is that they get pain here, particularly immediately postpartum. Someone thinks it's a pulmonary embolus and gives them anticoagulants, and in fact it was a liver rupture, and you're in an interesting position there. They have significant coagulopathy, and this is a group, unlike most acute liver failure, who bleed. They quite often can fit, they're jaundiced, and they might have hemolysis. If they've got hemolysis, think about TTP and atypical hemolytic uremic syndrome. They can present in pregnancy. It's a clear differential of HELP and fatty liver of pregnancy. This is an image of someone who did indeed present with pleuritic capsular pain, ruptured, and was given heparin. Big liver bleed. There is a risk in subsequent pregnancies, and genetic counselling and support is always important. Rarely think about viral hepatitis, HSV, particularly in the acute liver failures. These are a series of 3 patients we've recently had, got to send off for HSV PCR. For autoimmune liver disease, it is a rare presentation. One needs to consider it. Be very cautious about giving steroids outside the context of a transplant centre. There's clear data from the Paris group that one should be very cautious about giving steroids. You usually run into the complications rather than the benefit, so be very cautious. Veno-occlusive disease, thrombosis of the hepatic vein and sometimes going down into the IVC. Very classical CT image where you get this arterioportal shunting, this map-like pattern on CT imaging. This is the sort of histology, and this is the gross image at the time of transplant. Drug-induced liver failure we're seeing much more of. Obviously, there is direct drug-related toxicity, intrinsic toxicity, and the idiosyncratic ones. In these, again, where you've got drug-induced, always think about screening for viruses. HSV, CMV, EBV. There seems to be a synergy between viral reactivation and drug-induced toxicity. Also, increasingly, the pharmacogenetics of flucloxacillin, coamoxiclav, and some of the heart therapies, one needs to be doing the pharmacogenetics and predicting risk of liver injury. Obviously, for DILI, you've got hepatocellular, where you've mainly got cell necrosis, and you're looking at ALT, and the cholestatic, where you see mainly an increase in alkaline phosphatase. The ratio of those gives you this R number, which gives you the pattern of disease. This nice data from the USA acute liver failure group clearly shows that the incidence of drug-induced liver injury is seen mainly in the young people and also in the middle-aged. Women are particularly predisposed to cytotoxic cellular damage, whereas in men you see more cholestasis. DRESS syndrome is something you are likely to see in the ITU. This syndrome of eosinophilia, rash, lymphadenopathy, and fever. Frequent culprits being carbamazepine, allopurinol, sulfasalazine, and the like. Really serious disease, frequently treated with high-dose steroids, often goes on to liver transplant. Must consider it. Acetaminophen is my favourite disease because the English seem to have a particular predisposition to taking it. Toxicity at 150 mg per kg, often unintentional. It's just a cry for help. The high-risk groups, the anorexics, and those on enzyme inducers such as phenytoin. And clearly treatment is well provided in terms of N-acetylcysteine. And increasingly now people looking at paracetamol adducts to try and facilitate that diagnosis, work from the USA acute liver failure group. But the reality is that if you've got an AST or an ALT of above 7,000, it is usually hypoxic or paracetamol or co-synergy with viral disease. Hemophagocytic syndrome is always worth considering. This is a presentation you see here, a high INR, low platelets, and importantly, a very high ferritin of over 10,000. Here you see phagocytosis of red cells in the bone marrow and evidence of EBV. So do consider these rare diagnoses. This is where ferritin helps you in thinking of diagnoses where transplantation wouldn't be appropriate. Hypoxic hepatitis, as I said, a growing disease, usually seen in people with congested right hearts who then get a sudden failure of left heart flow, be it an arrhythmia, be it a drop in cardiac output for another reason. And again, you see this very high transaminitis. Worth thinking about, always supportive, doesn't need transplantation normally. Again, an interesting picture onto my last slide after this. High lactate, obtunded, but not necessarily liver encephalopathy, renal failure, high AST. This was all cardiomyopathy with a cardiac index of less than 1.5. Ended up on ECMO, both the liver and the heart improved. So don't always think liver, sometimes think heart as well. Similarly, ecstasy, you can end up with the most amazing pictures as part of a hypothermic liver injury. air right the way through the portal tract, all the way through the guts, temperature of 40, found fitting in a car park outside a club. You think that this must be an inevitable poor outcome. It's a young girl. In fact, this is on day 2 CT. The air is already being absorbed. Day 11, and a spontaneous recovery. So the ecstasies are very unpredictable. So, Chairman, ladies and gentlemen, the world is changing, both in terms of the epidemiology. Some of our diagnoses remain fairly basic. We carry on as clinicians. Teams make things work. And I look back on this. This was the book that was the first admissions book of the liver failure unit at King's. Amanita, halothane, don't see that anymore. Paracetamol, hepatitis A, hepatitis A, hepatitis A. The world has changed. Thank you.